positive and constructive indicator. On the same side, there are many individuals who are not good candidates for psychotherapy. I think anybody who's a psychotherapist certainly recognizes that there are many individuals who may be referred to their practice or for consultation who are not candidates for psychotherapy. They do not have the capability, either cognitively or in terms of their total personality integration, to be able to deal with a resolution of psychosocial problems and other problems which they fail to realize are significant in terms of their difficulties. For such patients, a simpler and more direct approach has been the use of medication. However, in a very recent seminar at the National Institute of Health just a few months ago, there was a consortium of psychopharmacologists, psychotherapists, neurologists, experimental investigators. And there is an increasing conflict in that follow-up studies with the use of antidepressants with depressed patients have failed to sustain a level of integration and a level of function which goes beyond the reasonable expectations that were first held. In other words, there is more disappointment at the present time in the long-term effects of pharmacologic therapy. That is not to say that many people are not helped, they are. But on average and in percentage, and in comparing psychotherapy patients with patients on psychopharmacology, there seems to be not a benefit from one as opposed to the other, but they seem to be about equal. In other words, there are as many failures with psychotherapy as there are gains with psychotherapy, and the same is true with psychopharmacology. When you take a large number of depressive patients who have been treated with drug therapy, you find that after a period of time, a high percentage of them have relapsed, and that the depressive episodes are recurrent. That's true also with psychotherapy. However, there is a growing sense that if psychotherapy is effective, and if it is able to alter and change the lifestyle and the life involvement and the psychosocial elements in which an individual is involved, that the lasting benefits of that therapy tend to be more effective than that of drugs. On the other hand, I think many clinicians at the present time are more inclined to look on something which is called balanced therapy. And there is no necessary conflict between patients using some medication for a period of time and being in psychotherapy. And what has been found is that in the initial stages, very often the use of medication helps to motivate the patient. It gives them a sense of increased helpfulness. They do not feel so desperate. They do not feel lost. They do not feel helpless. And therefore, their motivation for therapy increases. And then after a short time, one can drop the medication. So I think there is really a need, and I agree very much with the points you've made because I think they are unquestionable. But there is a need to balance and to integrate on an individual basis what goes on. On the other hand, there have been a number of studies in various centers in the United States which indicate that hypnosis, and it comes back to what I would like to begin a little while this morning, that hypnosis may significantly affect and expand the effectiveness of some medications. So that, for example, we find individuals who are taking antidepressants that if they take it and at the same time practice self-hypnosis, that there is a decidedly better result than if they do not use the self-hypnosis and the medication. There does not seem to be a conflict with regard to the two. There may sometimes be a conflict if a person feels they do not want any therapy and only want medication. That's a different issue. But certainly the use of hypnosis as a means of facilitating drug response is a very important one. And it really transcends the issue of psychiatric patients or patients with psychiatric or emotional illnesses. For example, a number of us have been working in recent years with patients with organic diseases, Parkinson's for one, multiple sclerosis for another, patients, of course, with organic terminal illnesses, cancer, leukemia. And we have found that one can potentiate the effectiveness of medication with hypnosis. So that, for example, it is possible with the use of hypnosis to increase the red blood cell count in patients who are undergoing treatment for cancer, particularly for bone cancer and for leukemia. And that the amount of medication that is required frequently becomes less. So that in a recent study, a number of Parkinson patients were seen who were taking various forms of dopamine as a means of controlling their tremors and some of their cognitive alterations which go with Parkinson's. And some of the side reactions to the medications, and in other instances, certainly with organic patients with cancer, are really quite severe. When hypnosis is employed productively, and when a patient is capable of utilizing it, and I always add the qualification that not everybody is a good candidate for hypnotherapy or for any other kind of therapy, but when they are, the amount of medication that is necessary can be reduced significantly. So that, for example, in a recent study which was confirmed with animal experiments, it was found that there are a number of new experimental elements which slow down the process of Parkinson, and that the amount of dopamine the patient requires is about 1/3 of what they required before in order to reduce and eliminate tremors and many of the other psychomotor as well as cognitive symptoms of Parkinson's disease. In a comparable study, it was found that the effective use of self-hypnosis comparably reduced the need. So that what happens, and it comes back to a very central issue, which is not what I'm addressing at the moment, but a little later on, is that hypnosis appears to have a stabilizing influence in terms of the central nervous system. As Orne and O'Connell at the University of Pennsylvania some years ago pointed out, hypnotic relaxation is not to be confused with simple muscular relaxation. That there is a totally different process that goes on which transcends or is beyond that, which is simple relaxation. Not that relaxation is not meaningful, it is. But I don't have a copy of it, but I would recommend that those of you who are particularly interested, that the study by Martin Orne and O'Connell, published about 7 or 8 years ago, I may have the reference here, which I can fish out for you a little later on. I do. I'll give it to you if anyone's interested. Indicates that the electrodermal changes that take place and some of the biochemistry changes that take place are significantly different in hypnotically induced relaxation than in relaxation without it. In a study which I participated in about 10, 12 years ago at the New York Medical College Hospital in Westchester County, we did a study with diabetic patients, with brittle juvenile diabetic patients who were hospitalized. And we're all aware that diabetes as an organic disease has many psychologic and emotional correlates. People who are diabetic get upset by emotional things, and when they get upset, their blood glucose levels begin to change. Diabetic patients, even those on insulin, are really generally advised to try to avoid stress and conflict. Don't get too agitated, don't get too upset, because for some it can precipitate very serious reactions. For others,
possono precipitare delle reazioni particolari.
For others, there may not be too great an impact, but in general, I think most specialists in diabetes would agree that the emotional level of diabetic patients becomes biochemically kind of fragile, and they are easily upset. And when they're upset, there are significant changes that take place in their blood glucose functioning. We did a study with over 25 inpatients with severe diabetes. They were severe enough to require hospitalization for that period of time. With their consent and with the hospital's consent, we did a very simple study. Since they were in the hospital, we could use a catheter to monitor their blood glucose levels constantly, not just using a venal puncture and getting a measure of blood glucose as might be done on an outpatient basis, but we could measure their blood glucose for 24 hours constantly and recording it. And what we did during this period at various times was we induced hypnosis. We taught these patients to use self-hypnosis for about 3 days before we began the second phase of our experiment. Second phase of our experiment was to use hypnosis to get the patients upset. This may sound counterproductive in terms of therapy, but we induced stress. We made them very angry, really angry. And I can tell you, one of my associates who was involved in this one case made the patient so angry that the patient raised his fist and punched the investigator and broke his nose. Now that's a lot of emotion. Now we were monitoring their blood glucose constantly through this, and in a separate room, we had 3 people who were not involved in knowing the nature of this study. They were all diabetic specialists, and they were from a different institution. They were from downstate medical school. And they were in the monitoring room, and they were just watching on the graph the blood glucose levels. And we said, we want you to tell us when you notice what you consider clinically to be a significant change or a noticeable change in their blood glucose levels, and to mark the time down because it's marked on the graph. We wanted to connect that with what we were doing to these people and making them at times anxious, at times angry, but really upset. And they got very upset. When we finished 2 hours of this, we went into the monitoring room, and one of the physicians, very capable man, said, you know, you asked us to watch these blood glucose changes. But he said, there are no changes. He said, I don't think these are diabetic patients. He said, it's perfectly normal. Well, I said, there are medication, of course. He said, yes, but there were no changes. And we said, at this time, did you notice anything? No, we had the running record and we compared it. After several months of studies of this sort, to give you a very summary conclusion, we found that what hypnosis does in diabetic patients is to stabilize their affective states. In other words, it is hard to get them upset. And if you do get them upset, it's behavioral and it doesn't affect their biochemistry. In other words, there is some kind of biochemical equilibrium which is maintained against stress, so that patients, these patients particularly, in self-hypnosis and utilizing hypnosis, could display the affect of getting angry, but their bodies did not somatize the aspect of getting angry. So that from this we have concluded that hypnosis is a very effective means of learning to moderate the physiology of our emotions without necessarily eliminating the expression of those emotions. In other words, had we given these patients large amounts of tranquilizers, had they been on a lot of Valium or Xanax or some of the other strong benzodiazepines, I suspect they would have been cow-like, and anything you do to them, they would just not respond to. These people were very responsive, they were very alert, they were very clear, but their biochemistry did not reflect the stress. They were able to tolerate that stress without these alterations. So that, coming back to where we started a little bit earlier, I think there is clearly a place and a role for hypnosis regardless of the other intervening variables that may be used in the treatment and management of all kinds of conditions. And we've been particularly gratified with the way in which hypnosis can be used in patients without psychiatric illness, in patients with hemophilia, for example, in patients with many other organic diseases, where it is possible, through the use of hypnosis, to stabilize their physiology, to stabilize their biochemistry, and to permit minimal amounts of medication to be used. In the way that Rudzinski and several others some years ago reported on the use of balanced anesthesia. For example, at the Hospital for Special Surgery in New York City, which is part of Cornell University Medical School, there is now a procedure which has become almost automatic. Whereas 15 years ago, when Dr. Albert Petr, who was the chief anesthesiologist at the hospital, initiated this, there was much conflict about allowing him to do this. And what he did was, and what he wanted to do, which he finally got permission to do, was to use hypnosis as a pre-anesthetic device with children undergoing serious and significant orthopedic reconstruction surgically. And what he wanted to do, and he worked with hypnosis as an anesthesiologist for a number of years, he was convinced that if he could use hypnosis as a pre-anesthetic, that he could use what's known as balanced anesthesia he could reduce the amount of chemical anesthesia necessary. And after a few clinical trials, he was granted permission. Today, and I'm kind of jumping some 10, 12 years, today it is standard operating procedure at special surgery for children undergoing orthopedic reconstruction, where the operations last sometimes 6, 7, and 8 hours, and they're very long, and the amount of anesthesia that usually is required is both extensive and goes on for intensity as well as a long duration. They have been able to reduce, on average, the amount of anesthesia that a child needs for a 6 or 8 hour operation by better than 60% when they use hypnosis as a preoperative procedure. The Veterans Hospital, Veterans Administration Hospital, is now using this procedure in many surgical procedures, ranging from hernias to open heart surgery, in which, again, the term balanced anesthesia, which many of you may be familiar with. There is a period of 1 or 2 days of hypnotic training and the use of hypnosis by a trained person, usually an anesthesiologist trained in hypnosis. And as a consequence, and I'll give you the results very quickly and simply, both at special surgery and in the VA hospitals, patients with a wide range of surgical procedures can be operated on with, on average, less than 1/2 of the amount of anesthesia that is normally required. Now, as we all know, there is more danger with anesthesia than there is with surgery. Certainly in the United States, the statistics indicate more patients die as a result of anesthesia trauma than they do of surgical failure. It really doesn't matter if you're dead, but it is clear that the anesthesia trauma has 2 phases to it. One, in those individuals who are precarious medically, it can precipitate their death. In others, we have a condition which many psychiatrists have seen, and it's known as anesthesia trauma. Patients after anesthesia, long, prolonged anesthesia, are sometimes emotionally upset for weeks and months afterwards. They were not neurotic before. They're now very agitated, they're anxious, and frequently it is hard to deal with these problems. To give you an illustration, some years ago, I saw a young woman referred by her surgeon because following a relatively simple but prolonged appendectomy, she became extremely anxious and nervous. She was crying, she was frightened. She had all the characteristics of an anxiety neurosis. But she had not had these characteristics before, and her family physician, who knew her for many years, said he didn't recognize these symptoms, that she was not a person with emotional problems. She went to see a psychiatrist, and after 3 or 4 sessions, he said, "I don't find any evidence of psychiatric illness, but you have symptoms." And he wanted to put her on a tranquilizer, which she did not want to take. Her internist then suggested, well, maybe we can use hypnosis to find out why you suddenly become so nervous. So I saw her, and here I may run into a little problem with translation, but we'll see if it works. I saw her, and in the first session, I said, I would like to use hypnosis to do just one thing, because I'm convinced that the psychiatric examination you had was competent, and that I don't think you have an emotional or psychiatric illness, but I think something has traumatized you, and it's something that started with the surgery. She was a good hypnotic subject, and she was able to enter into a revivification. She went back, and as those of you who have had revivification experiences with patients, she relived going into the hospital, she relived everything, and she was describing it as if it were going on. And she's now on the operating table, and she's describing what they're doing and how it feels. And then she says, oh my God, they're going to leave me here. This is terrible. I will die. They're going to leave me here. She heard the surgeon say, okay, here's where the translation problem is. Okay, let's go home. Now, I presume OR jargon in Italy may be the same as OR jargon in the United States. What he meant is, we're finished, somebody stitch up this patient, everything is fine. She only knew that they wanted to leave, they wanted to go home, they were going to leave her lying on the table. Again, in hypnosis, even though one may have acuity for the perception, There was a childlike level of interpretation of the language. She wasn't able to see the more sophisticated meaning of this. When she remembered all of this after the hypnosis and we discussed it, by the next day her symptoms were gone and never recurred. This was obviously one of the forms of anesthesia trauma that are experienced. There are many other forms that occur with anesthesia trauma. As a result of this kind of experience, people like Cheek, who is an obstetrician gynecologist surgeon in California, operating room personnel are now trained to be very careful about what they say. Because the patient's in anesthesia doesn't mean they don't hear. They may not remember much, and it is true, and some of the experimental investigations of interconversational activity under anesthesia indicates that many patients hear very clearly what goes on in the OR. They do not remember it, and it is sometimes difficult to retrieve it even under hypnosis. It depends on the level of anesthesia that was involved. To kind of go back to where I left off before this diversion, there are now a number of hospitals in the United States, particularly in New York, California areas, that are using hypnosis as a preoperative procedure prior to anesthesia and producing two generalized kinds of results. One, markedly less chemoanesthesia required during surgery, but even more significant, in follow-up studies with a variety of surgical procedures ranging, and I say on one hand, from hernia repair to appendectomies to open heart surgery to complex vascular surgeries to resections, colon resections. It has been found that those patients who have a period of hypnosis prior to the operation and who use it as part of the balanced anesthesia and can take less anesthetic chemically, their recovery is faster, they have less pain post-operatively, they require less medication for post-operative pain, and they are easier to manage as patients by the hospital staff. The nurses particularly are the ones who made these evaluations. These patients are cooperative, they're not depressed, they respond better to medical procedures, and they follow medical regime better, and they require less medication. So that, although it may be a little far from the work in neurotransmitters and serotonin levels and some of the other important brain mechanisms that are becoming increasingly clear, for example, with magnetic resonance imagery, it is really quite fascinating to watch what happens to patients when you just talk to them and you're having a running image formation taking place. There is activity taking place in that brain. And we have some preliminary evidences that when you intervene with drugs or with hypnosis or any other variable, that there are changes that really take place in the brain, not just in our minds. So that I don't see any fundamental conflicts, but I have a feeling that hypnosis can prove to be more effective in collaboration with whatever neurophysiological procedures and whatever psychopharmacological procedures may emerge in the future, because I think one simply enhances and permits the human body to adapt better to whatever procedure, even surgical procedures, even diseases. So that, for example, again, not to prolong this issue, patients undergoing radiation and chemotherapy for cancer are helped immeasurably with the use of hypnosis. The nausea, the vomiting, and the anxiety that accompanies chemotherapy sometimes, as many of you know, can be very intense and very distressing. In most instances, they can be managed and virtually eliminated with the use of hypnosis and self-hypnosis, which is undertaken sometimes only a week or two before the beginnings of either radiation or chemotherapy. This is a commonplace clinical procedure today, and there's nothing new or unusual about it. And I would say that at least half the patients currently, at least in my area, receiving radiation or chemotherapy for cancer undergo, usually with someone on the hospital staff, for example, at Sloan Kettering Memorial Hospital, which is the Center for Cancer Research and Cancer Surgery, Cancer Treatment in the United States. Jimmy Holland, who is the chief psychiatrist there, some years ago initiated a program where, if the patient is agreeable, every patient has access to a staff member who will work with him or her with hypnosis prior to the surgery, prior to radiation, prior to chemotherapy. And when compared with similar cases where either the patient does not want the hypnosis or in other institutions where they're not using it,